So the next speaker is Dr. Stephane Wen-Wei Ku. Dr. Ku is an internal medicine and infectious disease specialist training at the Taipei Veteran General Hospital. He's currently working as an attending physician at the Division of Infectious Disease at Taipei City Hospital, Renai branch, and researcher with Treat Asia at Taipei Veteran General Hospital. His research interests includes HIV, STI, chemsex, and sexual well-being of LGBTQ plus community. And he has been actively involved in PrEP implementation and mpox vaccination rollout in Taiwan. So today his topic is Chemsex in Asia Pacific region. Where are we now and where are we going? Please join me. Welcome, Dr. Stephane.
Good morning and sawadee krap, everybody. I'm very gladly thank the organizer to invite me back to Bangkok, one of my favorite cities in Asia, to talk about one of my favorite topics. It's chemsex in Asia Pacific region, and where are we now and where we are going. So today we'll talk about the definition, also the prevalence of chemsex among GBSM in our region, and also we are focusing on one of the substances that's quite important is crystal methamphetamine, how we define the problematic use and what's the harm associated with that, and also what are the interventions we have so far and what are the harm reduction strategies being used in our region and the challenges and future directions. So talk about chemsex or chem plus sex. The definition would be actually sex between men that occurs under the influence between or before sex and to facilitate or enhance the experience. However, the term chemsex is a pretty European way to address that. If you come to our region, for example, in Thailand, people usually use hyphen or ice fun. If you're in Taiwan, people will say BB hyphen, and also in Hong Kong, people will probably say chem fun. And if you go to the Northern America, they will be like party and play. So in different areas, the drug that being frequently used by the community or the name that used by the community will differ actually. So what are those substances that are being involved in chemsex? Apologize that this is a busy slide, but this is the review article that our colleagues, Dr. Carol and I, and also Adam from Melbourne were writing. So we are actually give some information, like a really basic information on all the substances that are being involved in chemsex. So the most commonly reported or classic chemsex drugs, or we like say the holy trinity of chemsex drugs, are actually methamphetamine, GHB and GBL, and methadone. So while methamphetamine and methadone are central stimulants, GHB and GBL is a central depressant, so acting like a very potent alcohol. Other drugs are commonly associated with chemsex in different part of regions, and that really depends on where you are addressing. For example, in Asia, a lot of time we'll talk about ketamine. And in other parts of the world, MDMA will be one of the most used drugs during chemsex. And also in North America or Europe, cocaine will be also frequently used drug in the chemsex sessions. There are other drugs that we have been seeing in the literature or in the chemsex scene, but they are not actually drugs that typically constituting chemsex drugs. They are drugs that are usually used during sex, so they are not always associated with chemsex. These are the poppers or amyl nitrites, cannabis or marijuana, and also other erectile dysfunction drugs. So just now, Eamon had cited very beautiful studies from Vietnam, also from Thailand, on what's the prevalence is among GBSM in our region. However, it's quite difficult to really specify exact prevalence in our in terms of Chemsex studies. It's really because all the numbers are quite different depending on the definition you use and also the population you're addressing. For example, from the latest data from Thailand, it reported 17.9% with Chems use among young MSM ever in life. So compared to the data from Singapore, it's around 5% with crystal mass use among young MSM ever in life. So while we are using different definitions, the prevalence will vary quite differently. Also, the way how people use these substances. For example, from the data from Australia, 14% are reported using crystal meth and 4.5% with slamming in the past 6 months or injection drug use. In Taiwan, we did this online survey every 2 years. So the latest survey we have completed last year showed around 9% with Chemsex in the past 3 months, and almost 27% people among people living with HIV. In terms of slamming, it's quite high. It's also 4.7%, with almost 16% people among people living with HIV doing slamming. So in the past few years, from our survey, we didn't really see a increase of the prevalence of Chemsex, at least in our country. Sorry. So there are recently 2 important meta-analyses published through 2 different teams trying to address the same issue, which is exact prevalence in our region. One is from our Dr. Thomas Gradamus from Mahidol University. So in his meta-analysis, 23 publications were included, and they found that methamphetamine was the default substance used in among MSM in Asia, followed by GHB, GBL, and ketamine, as we just mentioned. And also they found that there's a very little use of cocaine in our region. And they also found that MSM engaging in transactional sex and also people living with HIV are have higher odds of engaging chemsex. From another research group from Australia, they also included 18 publications in their meta-analysis, and they calculated the pool prevalence of sexualized drug use among MSM in the past 12 months was around 30%. So we probably would say that the prevalence in our region for MSM who engage in chemsex is around 10 to 15%. And they also found that such practice was associated with greater odds of cancerous anal intercourse and also living with diagnosed HIV. In the following slides, you will see there will be a lot of talk about how chemsex being affected our community living with HIV. And it's not very easy to address the cause-consequence relationship. And there were a lot of stories and also other structural reasons behind that. So we really encourage more qualitative studies on doing this. So we are now going to focus a little bit more on methamphetamine. It's not only because it's the default drug, chemsex drug in our region. Also, it causes more harms to our community, as well as it has a stronger correlation with higher riskier behaviors and also HIV infection. So in a pretty early study from the UK, the cohort study found that crystal meth, compared to other drugs, were more strongly associated with HIV risk and also condolences sex than other drugs. And also, overdose of methamphetamine can cause intoxication and also possible death. Crystal methamphetamine is a very addictive substance, and its long-term effects also include psychosis, delusion, hallucinations, and also mood disturbance and weight loss. By injecting crystal methamphetamine or slamming, it can cause other harms than the drug itself. It can cause local injuries or causing other blood-borne infections such as hepatitis C, HIV, and infective endocarditis. So since crystal meth becomes such an important issue among people engaging chemsex, so we would like to know what's the extent of harm that crystal meth have done to our community and how we can really address that. So we conducted cross-sectional online survey. It's called COMET study, or Chemsex online survey for men who have sex with men in Taiwan. We recruited MSM who have reported chemsex use in the past 12 months. So we've been asking them, like, what's the, if they have been used crystal meth. If they are reported so, they were being evaluated by SDS, or severity of dependence scale. So in this scale, if you score a point greater than 4 or 5 or above, that would be indicating for a problematic use or crystal meth dependence. So in our samples, we found that more than 40% of people who have been engaged in chemsex using crystal meth actually having a problematic use. It's quite stunning, I would say, because if you have been, I think most of people here are clinicians, and you have been working with your clients or patients who reported use crystal meth. But most of the time, they won't notice that they actually have problems. They will probably say like they were not using crystal meth every day, so they don't have problems. But in fact, if you really see these issues with this subjective evaluation, you will see that actually quite a proportion of people need help. And we are further to see how frequent people use crystal meth related to problematic use. So what we found is there's a very clear dose dose-dependent effect, that the more frequent that you use crystal meth, the higher your SDS score is. So people who had crystal meth more than once per month were actually related to problematic use of crystal meth dependence. And we further see how the harms were, how prevalent the harms is among our participants. So we separate the harms into physical harms, psychological harms, social harms, and legal harm. As you can see, eating problems and sleeping problems are the most frequent harms that are encountered by our community. And people living with HIV had more chance to experience these harms than people without HIV. So why people use crystal meth or chemsex? I think there are a lot of reasons. The greatest reason will be seeking for pleasure. But actually, study from Thailand show that there's more than just that. There will be something related to westernization, wealth, or social influencers, or peer pressure. So it will be very interesting to see how these affect our community and how we can work on that. So people are having chemsex are not having problems at the first time they use the substance. So it's more like a continuum. They might start it by just using this occasionally with their fixed partner, and then they start to get addicted and they are starting to have more problems. So it's very important for clinicians to identify at which stage our clients are and how we can manage accordingly. We're not going to have time to talk the details of these slides, but in the afternoon there will be a workshop. Also, I'll be presenting, and we'll use a case to demonstrate how in the clinic that we might address these issues. So in terms of interventions, the intervention with the greatest evidence would be cognitive behavior therapy, especially something called matrix model. So it's a 16-week treatment with combined approaches such as behavior therapy, family education, counseling, 12-step support, and also drug testing. So it's a very labor-intensive and also time-consuming approach, but it's very it's pretty effective, and it's the most robust. It has the most robust evidence so far. However, crystal meth is not like opioid. There's no replacement therapy available so far. So we only have some supportive pharmacological interventions that can help to add extra effect on our conventional cognitive behavior therapy, such as mirtazapines or long-acting naltrexone with bupropion. There are other clinical trials going on so far, evaluating the effect of antipsychotics, especially atypical antipsychotics, such on crystal meth dependence. So I think it's really important, since most of clinicians are not very familiar with cognitive behavior therapy, and also we don't have the time, we don't have the resources to do that. It's becoming important that we adapt harm reduction strategies, which is feasible, available, and familiar for us. So that includes HIV treatment, the prevention, and also prevention strategy and treatment strategy for other STIs. And that's, of course, clean needle exchange program, as Eamon just mentioned, like traditionally were being used in the opioid replacement therapy services, but it has to be adapted culturally to the GBM community. So these are all the details of the harm reduction strategies that can be used. These are, we'd like to let everybody know that it's not just being used during Chemsex. It can be proposed or to be adapted before Chemsex or after Chemsex. For example, before Chemsex, we can talk about PrEP, and during Chemsex, condoms and lubricants will be very important, especially as well as needle syringe program. And after Chemsex, maybe post-exposure prophylaxis would be something to discuss about. Talk about post-exposure prophylaxis is a very, it has been a hot issue about doxypep. So thanks to Dr. Iskandar, which is borrowed these from him. He's really, really kind. And he just made a very nice comparison regarding all the clinical trials using doxypep to prevent bacterial STIs. And tomorrow morning, there will be another hot debate on whether doxypep should be used among GBSM. So I encourage everybody to join tomorrow morning session. So most of the clients with sexualized drug use may not go to psychiatrists at first. They actually will probably go to your clinic as they are seeking for STI treatment or preventions. So it's important to integrate sexual health services to our Chemsex counseling together. So there are other like one-step services which have been models in the world. For example, Dingshi in the UK, and also like Lighthouse in Vietnam. Also in Taiwan, we have tried to demonstrate some of the services in Kaohsiung. This is our program from Taiwan CDC, which like to show that this is a publicly funded PrEP program, and we incorporated Chemsex services in the very beginning. So for the eligibility, you are either being young, key population, or people engaging in chemsex or sex works are being eligible to join the program. So one of the exciting parts of our field is how creative community can be leading the response. So these community-based harm reductions are now available in the world and also in our region. So we're going to show some of the strategies in our in Asia Pacific regions. So for example, this is Lighthouse. They come up with a very creative can care boxes and then distributed this even during COVID. So they are having outreach and with all these services available. This is from Taiwan. One of our NGOs will come up with the brochures that's showing some of the harm reduction strategies aiming for the frontline workers and also the community who have problem with that, how to do safe injection, for example. This is from Australia, Melbourne, and they have touch-based website providing all the important information on drugs and also how to play safe. They also have a community group called Rewild who can provide GBMs and who want to better manage their problems. They also have these adventurous men project who do outreach in gay clubs, on parties. They're not just distributing condoms or lubes. They are also oversee people, and once they have overdose problems, they are being sent immediately to the emergency room. And this is also one of the NGOs in Taiwan. They have a more structured setting in the mountains. They grow their own fruit trees. They have their own chicken, raise their own chickens. They just want like people who want to get away from the amphetamine and live in a more structured place for more than a year and return to a normal life. So, of course, there are challenges in delivering chemsex harm reduction. I'm not going to speak too much on the details, but actually, I think one of the major issues here would be having a constant and sustainable funding. And for most of the NGOs, they are really struggling on that. So what's the next in chemsex research? I think we have to come up with probably some standardized data and also how to provide safe supplies, will that be even feasible in our region? And also, for a lot of these practices, we need to have more evidence built. And so evaluation will be very, very important, not just for interventions, but also for like harm reduction strategies. So this is my take-home message. So chemsex, especially with problematic use of crystal meth, has constantly impact our community in our region. And besides cognitive behavior therapies and pharmacological interventions, harm reduction strategies integrated with sexual health services has been implemented, but we still need evidence-based and community-led harm reduction intervention with preventive strategy for HIV and other STIs, and we need to know its effectiveness and maybe its cost effectiveness in the future research. Thank you very much.